all to the 11th edition of the City Health Conference.
Witam na 11. edycji.
To see a room full of people. So my name is Katarzyna Kowalczyk and I'm representing the Global Public Health Network, the organizer of this event. And this is the first event that we are able to hold live since the GPHN was established back in March 2020. This event is also very special because this is the first time we are holding City Health Conference in Poland. So one of the goals of GPHN is to bridge the gap between science, policymakers and academics. So bring together people working in a wide range of sectors and enable them to collaborate, to share their experiences. And just by looking into the audience, I can tell and I can see that we have representatives coming from different backgrounds. So I do hope that we'll be able to have conversations, discussions, and just human-to-human contact, although following all the mandatory rules and restrictions. So crisis, risks, and opportunities. This is the theme of this year's conference. And there is a great deal of learning and knowledge to be shared from experiences of delivering services before and during the pandemic. So over the next 2 days, we will have many examples of this. There are also live participants with us, and I would like to welcome them all. And I would like to encourage them to use our virtual platform and to engage with each other, to use chat, to ask questions to our presenters as well. So I hope you're gonna enjoy this event. And right now I would like to invite Magdalena Roszczyńska, who is Vice Director of Robert Zając Institute for Social Studies, University of Warsaw.
Ladies and gentlemen, good afternoon. It's my pleasure to welcome you at this conference, all of the participants online and on-site, on behalf of the Robert Zając Institute of Social Studies from University of Warsaw, an academic partner of this conference. We are happy to be here. Our institute has a long tradition of international and interdisciplinary research in a topic strongly connected to the topic of this conference, today's conference. We are therefore happy to use this as an opportunity to present our work and ideas and discuss it with the wider community of practitioners and activists working in the field of urban well-being, crisis response, and harm reduction. Tomorrow afternoon, our team from Civil City Lab, which is a part of Robert Zając Institute for Social Studies, will present relevant and very interesting projects that touching upon the right to wealthy city. And we warmly invite you to join us. We promise to make it interesting. As part of University of Warsaw social responsibility mission, we strive to make our work relevant for society and residents of this city mostly. We are proud to be involved in in expert work on projects together with the city of Warsaw. The work we done was connected to the Warsaw strategy of solving social problems 2030 and Warsaw Development Strategy 2030. These two processes allowed us to moderate discussion among the diverse groups of citizens, city administration, public institutions, and NGOs. As a result, we arrived with a document that lists the new challenges that we are facing in context of further development of Warsaw. We hope this conference will be next step to stronger connect practice with academia for the healthier city of tomorrow. Thank you. And now I would like to invite Ms. Grażyna Cieślak from the city of Warsaw, who was responsible for the development of the strategy for solving social problems 2030.
For a greater diversity, please allow me, I will speak in Polish. W październiku Rada Miasta Stołecznego Warszawy przyjęła strategię
Municipal Council for the City of Warsaw adopted the strategy for resolving social problems that will hold valid until 2030. And it is a very important document in a dynamically developing city. The residents of Warsaw, they are very positively inclined toward the city. They identify themselves with their hometown, that they love living in Warsaw, but at the same time, however, they feel some pressure, which is caused by the speed of life in a large city and the requirements of the labor market they have to face. That's why we are observing lots of behavioral disorders, some risky behaviors such as violence or addictions. And therefore, we have defined 4 strategic objectives being part of our strategy. First of all, we would like to support independence. We would like to support people who need help and support in the individual functioning. Still in Warsaw, they are confronting various limitations, restrictions, barriers, and indifference too. On the other hand, we would like to have our social services which are targeted at people confronting some predicaments. We would like to have them custom-tailored and individualized, taking into account the specific needs and requirements of families and people. For some time now, we have an impression that this mission of this positive support and help is deeply rooted among our social workers. That's why we are going to build a positive image of social support. We are deeply convinced that our social workers deserve that kind of help. And this is what our research proves as well. Another objective is related to health and good relations, because in my view, there are very important factors, protective factors, and which help us to limit risky behaviors. Of course, we are going to continue and to develop also specialist support and specialist services, but they will be complemented by a very important aspect of interpersonal relations and health. Our 4th objective is related to inclusion and engagement, rather, of all people into help. And we are going to promote and advocate social solidarity among residents of the city. In the face of the pandemics and social problems related to health, we've noticed a huge social potential. And that's why we would like to support this positive initiative among our inhabitants. And when this strategy is now in place for for 1.5 of months, we are now also planning to work on other documents which will help us to solve other social problems. For instance, we have a Charter of Rights for people who experience homelessness, and there are some other programs related to preventing addictions and some programs supporting families in difficult situations. And of course, we are supporting also various actions by which we would like to obtain these objectives. So there are some difficult situations such as homelessness, violence, addictions. These are very important objectives for us. And we would like to listen carefully to your presentation, because I'm quite curious how you managed to cope with this challenge for institutionalization, because I believe that in large cities, large urban areas, it's a long-term process, but at the same time, a very interesting process. So thank you very much once again for the invitation. And I'll be watching carefully what you have to say, and so will my colleagues.
You could join us.
Well, good afternoon. I can say I'm genuinely delighted to be here at the 11th City Health International Conference. Very much appreciate everyone managing to get here, particularly our presenters. I was minded when I looked at the topic that we're going to discuss in this session, that one of the last events I went to before the COVID pandemic changed everything was actually something on homeless and inclusion health in London back in March 2019. And I guess it reminds me of the fact that I've been involved in many initiatives at national and London level, which have both said that they're going to end homelessness with people sleeping on the streets of London. That's been general election commitments, mayoral commitments. We certainly made commitments that we were going to end it before London hosted the Olympics in 2012. You don't need to be an expert of English social issues to know that none of those commitments actually did solve the problem. But one thing we did see during the pandemic, not just in London, but as you're going to hear in many places and around the world, was something that did, albeit temporarily, actually see people coming off the streets. We've got 4 great presenters, the first of whom, Emmett Roberts, unfortunately was going to be here with us, but as he's got clinical duties and we've just changed the restrictions on travelling at the moment, hasn't been able to join us, but he will will be joining us online. Now, Emmett is the Clinical Research Fellow at the National Addiction Centre at the Institute of Psychiatry, Psychology and Neuroscience, an Honorary Specialist Registrar in General Adult Psychiatry at the South London and Maudsley NHS Foundation Trust. I actually had the privilege of, in a small way, being involved with some of the work he did at the beginning of the COVID-19 outbreak, where he provided the clinical lead for the Homeless Hotel Drug and Alcohol Support Service in London. Now, this was the first pan-London commissioned drug and alcohol service, but it provided alcohol, tobacco and drug support for those individuals who are experiencing rough sleeping and housing them in hotel accommodation across the capital. And I hope very much now that I'm able to hand you over to Emmett.
Very much for having me. Thank you, Dave. And yeah, apologies. The 11th hour Omicron variant has slightly prevented me getting to see you guys. So I'm Emmett. I'm an addiction psychiatrist by background and also an academic at King's College London. And as Dave said, at the beginning of the pandemic, I found myself in a slightly new role running what later became known as HDAS, the Homeless Hotel Drug and Alcohol Service, which I'm going to tell you a little bit about today. So, as I'm sure you all know, in March 2020, when COVID hit and lockdown was imposed, the UK government, as part of its policy response, enacted an initiative that was known as Everyone In. So it basically directed local government to temporarily provide housing, emergency housing, to those individuals who were rough sleeping within their areas. And within London, that at its peak over lockdown meant that the various local government organisations procured around 70 hotels, which housed about just over 5,000 people at its peak. The way these hotels were organised was they were all individually run by homeless sector charitable organisations, but they were designated into 3 different types. The first being COVID care, which housed people experiencing symptoms or who tested positive for the virus. COVID Protect, those who weren't experiencing symptoms or who were negative but had medical vulnerabilities to the virus, and then COVID Prevent, everybody else. And it was realised quite early on that there was a huge amount of substance misuse comorbidity among the individuals who were coming into the hotels. And so as part of the funding that was released to procure accommodation, funding was additionally released to create a new bespoke virtually run drug and alcohol service specifically for the population of the people that were in the hotels. And that's what became HDAS. We were initially commissioned for 3 months, and then obviously as things developed and as time went on, we were extended and extended and extended, and the service is still running today, albeit with one of my colleagues now very much in the driving seat and doing an excellent job. I'll just give you a little bit of an overview about what the service did, and then I'll come on and talk a little bit more about the specifics in terms of the challenges and the opportunities and the things that we learned. But we can really sort of split it into 4 different areas of what the service achieved or didn't achieve in some ways. It was very much a learning experience. The first was providing clinical support. So we had a 24-hour initially and then a 9-to-5 telephone and email line that professionals from the hotels could call us on to seek any advice or thoughts that they, or any worries or queries that they had about substance misuse. A lot of people were obviously going into self-isolation, and there was a lot of unplanned withdrawal from alcohol, opiates, and various other substances that people needed specialist support to be able to manage. So we had a telephone line they could call us any time of the day. We also provided stuff, so harm reduction materials. So we provided lock boxes for people to store drugs in, naloxone, the antidote to heroin overdose, clean needles and syringes, distraction packs and workbooks for people to work through in their rooms, and also a variety of nicotine replacement products, including electronic cigarettes. We also provided some training. So a lot of the homeless sector charitable staff had not had any specific substance misuse training before. So over the course of about 6 months, we trained up about 65 people in how to deal with people who had substance misuse issues. And finally, because the service existed, it really just gave us a sort of place at the table so that whenever any high-level discussions were happening among London government officials or within the public health system, it meant that we were able to represent substance misuse and explain how addiction perhaps needed additional thoughts or additional things to be done because of it. So I'm going to just run through a little bit about what we learned about alcohol, tobacco and drug harm reduction. And just to say that we've published a number of reports on this. The references of these are all available at the end, and I'm also very happy to be contacted or to take questions about it. So in terms of alcohol, so before going into the hotel, we conducted some work to see what the level of need was out there, and alcohol was causing some form of negative consequence on about half of the hotel population's mental or physical health. So about 50% of the people were using alcohol harmfully. Alcohol was our most common subject of telephone and email contacts from hotel staff who were seeking advice and support about it. And it was the most common reason for new referrals that we initiated into specialist addiction treatment. So this is just a snapshot of our first 6 months of work. So out of 75 new referrals into treatment, these are people who were brand new to treatment, just over half of them were due to alcohol. And it was also the most commonly cited substance in the event of an individual being threatened with eviction from hotels. So just a little bit about some of the things that we did. So we realized very quickly that there were a lot of people suffering from alcohol dependence who may need to go in and self-isolate, or if they were testing positive or displaying symptoms. They obviously had no ongoing access to alcohol, and it was very difficult for us to to manage detoxification programs from a virtual perspective, and we also didn't think it would be clinically appropriate. So we initially bought a whole bunch of alcohol. We prescribed and provided daily rationed alcohol doses to prevent the risks of unplanned alcohol withdrawal. We became very friendly with a lot of Uber Eats drivers who couriered a lot of booze for us across the city. You know, this is often typically termed a managed alcohol program, or using alcohol to manage people's withdrawals. And we provided sort of the first real world example of a successful managed alcohol program that was run completely virtually. Sorry, excuse me. So in this very unique context, our map secured a huge buy-in from a range of stakeholders, from hoteliers to homeless sector staff. There can often be resistance in providing alcohol to people who are alcohol dependent from a sort of moral standpoint among a lot of people. But actually, we managed to secure buy-in and from all people to prevent withdrawal and ultimately save people's lives. And it became a means of engaging people in discussions around their alcohol consumption. And actually, people who'd never previously wanted to get into treatment, suddenly, is because we were providing them alcohol and keeping them safe, were able to engage in conversations around their alcohol use, and ultimately some of them access treatment. If we think about illicit drugs, so illicit drug use was reported by about 20% of the population. And it was responsible for just under half of our referrals into specialist addiction treatment in our first 6 months. These are the most common substances that we use. So opioids, the most common, followed by synthetic cannabis, cocaine, and herbal cannabis. And again, illicit drug use was also a commonly cited reason for individuals being threatened with eviction from the hotels. So what did we do? As I mentioned, we distributed quite a lot of physical stuff, so including lockboxes for safe storage of opioids, needle exchange packs to give people clean syringes for injecting, and about 100 kits of naloxone to prevent opiate overdose. These, again, were universally well received by most professionals and also by the residents in the hotels. We also were able, because of our links with local services, we were able to get people into drug treatment quickly and initiate rapid prescription of opiate substitution treatment for those wanting to enter treatment. A lot of our services shut down or became virtual over the course of the pandemic, but because we were working across London, we were able to slightly break down some of those barriers and get people quickly into treatment where they needed it. As I said, we provided training to about 60 members of homeless sector staff, and that included overdose awareness and how to administer the opioid antidote, naloxone. We also facilitated discussions with hoteliers who were quite reluctant to allow drug-using individuals, particularly into their hotels to start with. And we worked with law enforcement agencies in London to provide what we subsequently dubbed letters of comfort to hoteliers, that people wouldn't necessarily be prosecuted for Class A drug possession, which took some doing, but was very useful in the end. And finally, just thinking a little bit about tobacco. So tobacco cigarettes were smoked by about 80% of the population going into the hotel. Obviously, tobacco and cigarette availability was reduced during lockdown due to the closure of non-essential shops. And also people had less access to finances than they had previously. So there were significant reductions in begging and sex work. So a lot of people could no longer afford to purchase cigarettes or tobacco. Just as an aside, the United Kingdom banned tobacco smoking in closed public places from 2007, and so residents couldn't smoke in their hotel rooms, even if they were required to self-isolate due to symptoms of COVID-19 or testing positive. And as you might imagine, tobacco smoking was also a commonly cited reason for individuals being threatened with eviction or being kicked out for smoking indoors. So what we did was we sourced a bunch of tobacco harm reduction products, most notably about 3,000 electronic cigarette starter kits and refills, which we distributed to among the hotels alongside other nicotine replacement products. These were really, really well received by professionals, and it meant that people could vape indoors. It resulted in fewer evictions, and it meant that people could self-isolate while still getting nicotine, and they weren't then going out and potentially spreading COVID-19. So yeah, we've produced a report on the tobacco harm reduction stuff, which is referenced here. But yeah, the overall findings were that it led to some anecdotal reductions in residents breaking lockdown or self-isolation to buy tobacco, led to reductions in people sharing cigarettes or picking up stubs off the street, which obviously would increase their risk of COVID infection, and it reduced the risk of them being evicted. So just a little bit about breaking down barriers in terms of accessing treatment. Individuals who experience homelessness often access specialist drug and alcohol services and stop smoking services less frequently than those in the general population, though we know that they have a much greater need. They're typically referred to as sort of hard to reach, which in of itself can be quite stigmatizing language. However, there were loads of misconceptions both among residents and professionals about who was entitled to access drug and alcohol and stop smoking services. And these are some of the quotes that we heard over the course of the service. You know, I don't have any ID, I can't go to services. I don't have a fixed address, therefore they won't take me. I don't have a GP, I'm not entitled to receive care from a drug and alcohol service. How does my immigration status affect this? I don't want to risk being reported to government. I don't have any money. You know, I have no recourse to public funds. So this is a specific status in the UK whereby overseas visitors who have immigration difficulties cannot access publicly funded money or services. However, so our law states that drug and alcohol services are classified as primary medical services, and anyone can access them free of charge, irrespective of their immigration status or irrespective of their overseas visitor status. And so we produced these leaflets just to give you another idea of the kind of thing that we tried to do among this population. So these are the kind of leaflets that we shared among the hotels, just highlighting that individuals didn't need a fixed address, they didn't need identification, their immigration status didn't matter, you don't have to pay any money to access drug and alcohol services. Yeah, as I've said, they're freely available to overseas visitors. Services should never ask to see a visa or proof of immigration status as a means of determining eligibility in England, and an inability to provide identity or proof of address aren't reasonable grounds to refuse a person access. So informing people about these was key to engaging people and getting them to access services more during this period. So just a little bit about the funding in the future. As Dave said, the UK government has once again pledged to end rough sleeping by the end of this parliament, which is 2024. And so far, an additional £80 million has been invested in drug and alcohol services in what are being termed priority local authority areas with high numbers of people who experience rough sleeping. And whilst, you know, and more money for drug and alcohol services is always very welcome, it should be noted that this is on the background of a £250 million disinvestment in drug and alcohol services since 2012. So yeah, as I said, the service has been extended until December 21. It looks likely it will be extended further, but we slightly watch this space. So here are my contact details, and here are some of the reports that we've published over the course of the last year about the work within HJAS and the work of everyone in. Please feel free to have a look at them or contact me with any questions. And thank you again for having me.
Thank you very much, Emma. We're now quite appropriately going to move from London to Warsaw, and I'm very pleased to welcome our next speaker, Jacek Harmas, apologies, who has 20 years of experience working in the harm reduction field. In 2002, he initiated the Harm Reduction Centre in Warsaw, and in 2006, a shelter for people undergoing methadone treatment and a daycare centre. From 2003 to 4, he was secretary of the Mono Association Board, and today Jacek presides over the Jump 93 Association, which supports opiate substitution patients. He is a founding member of the Polish Drug Policy Network and the creator and administrator of the Office of the Ombudsman for Addiction Services. That's it. Mogę przerzucać? Okay. Dzień dobry Państwu. Parę słów komentarza.
Good day, and so starting from a short commentary from my predecessors, so we are trying to persuade the organization that cooperate with us, which are dealing with supporting homeless people, to consider an idea to change and replacing smoking tobacco for electronic devices, and they don't succeed in doing that. And our hostel, which is a small hostel for people addicted from drugs and from homeless people, we suggested for 15 people, so free of charge, electronic devices. Only one person took advantage of our proposal, and it is a very difficult topic, to cover, but it's a very important topic at the same time, because smoking tobacco at shelters is is a nuisance and results in evictions of people from shelters, and we have to work on that. And regarding my presentation, so we have like 4 parts of a presentation. The first part of a presentation, I'd like to outline the Polish system of helping the addicted people and tell you why it's so difficult for us to help people who actively use drugs, and how difficult to help people who are homeless. So, ladies and gentlemen, now the first center and the first stereotypic society, we can say, and the first center which started to dealing with the providing professional support to addicted people, specialist support, originated in 1978. It was a therapeutic society which was based on and modeled upon of American centers, and they were highly successful. The organization which appeared at that time 2 years ago, then we created in this part of Europe, we've created the largest system, the largest structure when it comes to helping people who are addicted to drugs. The originator and creator of that method was Mr. Marek Kotański. Well, we didn't have good contacts with Western countries, Western Europe at that time, so we have to test everything on a live body here. We didn't have any specialist literature, any exchanges, any networking at that time. So as a result, so today in Poland, we have roughly 80 inpatient facilities, which are therapeutic societies, and there are more than 220 outpatient facilities, out of which approximately 100 are specialized units dealing in drug, and they are in charge of 70% of all services contracted by payers, and each major city has got such an outpatient facility, and there are a dozen or so outpatient facilities in Warsaw, so it's not a bad situation in Poland, really. And if you take a look at the epidemiological data, we can say that there are roughly 3 million of people who admit that they're using more or less drugs, and out of this group, there's 100 of people who get into trouble out of that, because of that. And so they appear at our inpatient facilities and outpatient facilities. There are more in inpatient facilities than in outpatient facilities by a half. And when we think about these forms of support, it's available forms of support, and I think that there's nothing more to be added regarding the availability of. However, when it comes to the quality of such supports, I believe that there is much more to be done, And we have these detoxification centers. I think we can have even more centers, but it's not that bad. I think that these are the most available medical services in Poland, the medical services that I mentioned. When I think about the therapeutic societies, well, you don't have any specific preferences like a double diagnosis, so you can get there just another day. You can get for detoxification from hospital. So I believe that there are no queues, and rotation in these therapeutic societies is huge. I don't think that efficiency has been studied thoroughly, but I believe that maybe roughly 10 or 20% of people who get for such treatment, I think that over a longer period of time, they can stay out of drugs. These are, of course, drug-free facilities. There's only one facility which accepts people for substitution treatment. And in a while, I think we will just cover that topic too. So when it comes to the social reintegration or resocialization, I think that's a continuation of or some interim programs, and there are led by the hostels and other places, institutions. So these institutions, these inpatient institutions, I believe that there are some problems with that because those hostels are located in some places which are not good for integration and team building and integration. So I think that these are just rural areas which are quite distant from urban areas and quite distant from labor market, and this is not a good thing. And this distance from the labor market is not a good factor when you think about the integration of those people. That's why such places often remain empty. When we think about the substitution programs, we have 25 substitution programs, 5 of which are in Warsaw. 2,500 of people are undergoing substitution treatment. Out of that, 1,200 are treated in Warsaw, so in the city, like roughly half of these people are treated. When you think about the harm reduction program and the syringe replacement programs, there are 13 such programs, out of which 4 can be indicated as programs which are structurized with long-term support, offering a lot in terms of social reintegration. So what I mean are the programs that are based in Wrocław, in Warsaw, and one of them based in Krakow. Well, what you can see is like one of the therapeutic societies so accepting people who are undergoing substitution treatment. It's now near 50 kilometers of Warsaw in Kazyn-Bielany. It's one of the oldest Polish inpatient facilities. So what is the problem with care or taking care? I have some problems with the slide projector here. Or with this equipment. So, ladies and gentlemen, so what's the problem with the harm reduction in Poland? So what's the problem with the scarcity of places when we can accept people who are addicts and who are actively using drugs, and we don't have any places for people who are undergoing a substitute treatment? So the professionalization, well, the reason is that professionalization of our work with addicted people, and that systemic professionalization, it's not a long story. It's a 40 years duration of the system, but this professionalization is like half of that. So 20 years ago, I think that this professionalization started, and we've got now good therapists who have been learning their profession for many years now, and then they're passing their examinations. And basically, at their schools of therapy, they learn that addiction is an illness. But we've been also taught for 40 years that addiction is a choice, is a separating from problems, that everybody can deal with that if they want to. So I think that this approach is a 40-year-old approach. It's still in place, is still functioning, and the result is that many regions of Poland are deprived of harm reduction programs, especially the eastern part of Poland. I do apologize, I have some technical problem again. So anyway, so when you think about the reintegration, I think that the most care is provided for people who completed their therapy in patient facilities. So they are offered various services and programs related to, for instance, coping with violence or relapses or any job orientation programs. So this group who is still actively using drugs, they are deprived of any such assistance. Based on the studies from the National Bureau for Prevention of Drug Addictions, 20% of clients, of customers of the low threshold programs, harm reduction products are people being permanently in the crisis of homelessness. And their status, when it comes to their permanent residence, is undefined, because perhaps there are even more such people, but generally we believe that in major cities this ratio is even higher, like for instance in Warsaw, and for instance Warsaw or Wrocław or other Silesian cities. I believe that they have to use their own resources to cope with that problems. We have already taken some steps to overcome this problem in Warsaw, but anyway, I believe that it is still not enough. Still, there are many Polish therapists who believe that the social reintegration should be limited to those people who maintain absolute abstinence after treatment. In the Mazovian region, in our region here, and Warsaw, there are many programs that are in place, programs of overcoming homelessness, homes, shelters, therapeutic centers for people with problem of alcohol, and many other programs are provided. So 1,500 people are beneficiaries of such problems, but maybe 1 or 2% of those places is dedicated to people who are using drugs. Even have the shelters for people which are low threshold places, and I believe that people using drugs have they don't have much difficulty in using such support. So I think that they don't find much difficulties in using such forms. But at the same time, they are also often subjected to violence on the part of other clients, of the inmates. And I think that the staff of such facilities, they don't know how to cope with such problems, and they really refrain from coping such problems. They don't want to really interfere when there are some arguments between clients. And there is one important project that this municipality is working on together with non-government organizations, is on the other side of the Vistula River in Praga Północ district. Is a Restart Center project. And this project is dedicated to 3 groups of socially excluded people. And there are senior people, there are homeless people who require medical assistance, and there are people who are addicted to narcotic drugs. And Warsaw allocated part of the hospital in Praga to create and to accommodate such center. And I think that this part, or this section, is like 3,000 square meters. And this 3,000 of square meters have been divided into 3 main functions. So I can't tell you much about this project because this program is still, discussed with different social actors. But I think that the project has been already advanced, and I believe that next year the facility will be released for use. So when it comes to senior people, I believe that this program will mainly help to rehabilitate these people, to provide them with some entertainment too. When it comes to homeless people, I think that the function has been targeted, especially for people who require medical assistance, and that part which is also for people who are addicted for drugs, I believe that it will also incorporate some functions which are targeted at people who are actively using drugs. So we really hope that there will be some harm reduction programs, social readaptation programs, medical assistance, social support, legal assistance, all these services. So we would really expect to have these services rendered by the center. So now let me tell you a couple of words about our association, which in Warsaw deals not only with support for homeless people, but also deals with some activization of that people, and also supporting and advocating for their rights. So we are acting as an advocate for those addicted people, and we managed to do a lot also in Warsaw and all over Poland. We managed to inspire new substitution programs in many cities, and I think that in our assistance in Gdańsk, in Opole, in Olsztyn, so a Wrocław program has been extended a lot, and in Warsaw we are also trying to create small-sized programs which are experimental in a way. So currently we are having some readaptation apartments for 5 people, and we have, like today, we have 12 people with accommodated in another venue, and we have also a daycare center in Augustów for 8 places, and we have also a tent campsite, and we are also using this campsite from that year onwards. And I think that was our response to the lockdown situation. We needed such a venue in a nice region near the lakes. It's a nice lake region. So to provide people with an opportunity to do some active activities and to help our clients to overcome the COVID situation and overcome these mental problems that occurred as a result of COVID pandemics. So this is our readaptation flat apartment, which accommodates 5 people now, and it's located in Warsaw as well. And now we have this social reintegration house in Augustów, and we have people who are undergoing drug substitution therapy, and whenever it's hot and the weather is nice, they just move on to that place. And on that slide, let me tell you something shortly about our financing system. So we have to use our own funds, our own resources, so there are not much money. Last year we had some grant from the municipality for refurbishment and redecoration works, and we've got some EOG grant, EEF grant, which helped us to operate and open our facility in Augustów. And also we have some subsidy for supporting our readaptation apartments in Warsaw. Thank you very much. That was all.
For overcoming the technical hurdles there. We're now going to look towards Scotland and some work in Edinburgh and Glasgow. And I'm pleased to introduce Rankin Barr, who was born in Ayrshire in Scotland and joined the Metropolitan Police in the 1980s, serving in North and East London. He then studied addiction at King's College, University of London in the 1990s, and was involved in delivering the first arrest referral and criminal justice diversion schemes in London. It was about this time, actually, Rankin and my paths crossed for the first time, and he used to work with me when I was at the London Drug and Alcohol Policy Forum, and he was a Drug and Alcohol Action Team manager for a London borough. In the early 2000s, he was appointed a Drug and Alcohol Action Team manager for Lincolnshire County Council, that's in the east of England, and later became head of the county's Drug and Alcohol Services. Rankin has served as the registered manager for prescribing and recovery services in Suffolk. In 2009, he returned to Scotland and has been working in the third sector, the voluntary sector, for over a decade in a variety of roles as a director, trustee and service manager in various parts of Scotland. Most recently, he was helping set up the first sort of fixed, planned, if you will, managed alcohol programme in Glasgow. Rankin.
Okay. Well, from one beautiful city, this beautiful city of Warsaw, to another beautiful city in Scotland, I'm going to tell you a little bit about the emergency response that we had in the city of Edinburgh. As you gathered from David's introduction, I'm not an academic. I don't pretend to be. I am a practitioner, and I've been delivering street services for nearly 25 years. I shall try and keep it relatively slow for the ladies in the booth there, because I'm aware that my Scottish accent is sometimes very difficult to understand, so I apologise for that in advance. I want to, first of all, start today by telling you the challenges that we were given by the Scottish Government and by my Chief Executive at the time. I was working for the Simon Community Scotland, the largest homeless charity in Scotland. and I was covering the Edinburgh area, and I was asked to lead on the instigation of a programme of events which would hopefully take all the homeless population off the streets to protect them from COVID-19 and to give them an opportunity which they didn't currently have. To put this in context, this is the kind of timeline that the UK government were going through at that particular time. The Prime Minister was speaking on the 16th of March about starting to limit travel and limit contact, and actually on the 18th of March we had the first presentation to our open access service in Holyrood Hub of a homeless man, a Polish homeless man actually, who arrived at the premises with COVID symptoms. And it became very apparent at that point in time that public health in that particular moment hadn't actually developed a pathway or accommodation or a policy, if you like, on how to deal with the homeless population who were out there, despite the fact that we were already talking about lockdowns and making it illegal to not to self-isolate. So essentially, my organisation contacted the Scottish Government with a proposal to use hotels that we had already identified and come to agreements with, in order to bring these people off the streets and to protect them from the virus and to give them opportunities that they didn't currently have to deal with their addictions problems and all the other problems that came along with the street population. So the first thing we did was start to look at who are the main players in Edinburgh at the time, and we had a fantastic group of people called the Interagency Street Network, where we all met every Thursday in order to discuss the homeless population and those people that were the most vulnerable, the most at risk, and sometimes the most risky that were actually living in our communities on the streets. So the City of Edinburgh Council obviously ran all the homeless departments, and public health and the NHS had a number of responsibilities within that. And it was agreed by public health, because of our proactive approach to this, that we would lead on the homeless pathway for the City of Edinburgh. This is the actual document that I presented to them at the time, where we didn't take this as two separate hotels. We took this as a whole systems approach. And we utilised all the current services which were there as part of a system to find the best accommodation which met each individual's needs when they were brought into the assessment centre. The assessment centre was kept at the Holyrood Hub, which is the largest and busiest service in the whole of Scotland, receiving around 1,800 presentations a year. Now, I'm going to mention food because it's a great love of mine, apart from anything else, but one of the biggest challenges for us was bringing 120 people off the streets. We then had the responsibility to keep them there and actually, retain them in these premises and trying to do something really meaningful with them, rather than just simply dumping in the hotel and asking them to survive. And one of the biggest challenges was we ended up feeding over 300 people. We had 200 pickups every single week run by volunteers. We had lots of restaurants who'd shut down, who actually motivated, brought their staff in and brought their chefs in and actually cooked for us. And they didn't do that for a week, they didn't do it for a month, they did it for 6 months. And they did it at no cost to the public purse. So if you're looking at community activism and people coming together for the benefit of the most vulnerable in society, I think Edinburgh really came together at that particular time in the site of COVID. Now, the two hotels that we chose were the Cairn Hotel and the Meredith Hotel, and we chose them independently because we wanted to have a smaller hotel for vulnerable people who were vulnerable particularly because of pre-existing conditions to the virus. So the Meredith was kept as a unit, if you like, for those very vulnerable people. And the larger accommodation, the Cairn Hotel, had fantastic variety of accommodation, which was really unusual. We had 3 beautiful multi-million-pound Georgian houses. We had a cottage in the back garden. We had apartments, and we had different types and styles of rooms that would meet different people's needs. So we adopted that hotel because of those things. And I want to talk about achievements and positivity. We're often, you know, we don't discuss the things that actually do work and the things that we do achieve. And our main achievements were there was 346 people over that 6-month period came through this pathway successfully. And we're really proud to say that every single person who came through that was accommodated if they managed to stay within the accommodation. We had no deaths. We had no serious injuries, and drug-related deaths, which is a massive problem in Scotland, some of the worst problems in the whole of Europe, actually dropped because people were being cared for, and naloxone was everywhere, harm reduction was everywhere, and everything was delivered on site. I know in London they used single points of contact, and we went for clinicians, a one-stop hub, GP surgery on the premises, and everybody came together. We had same-day prescribing. You know, people went on to methadone that day if they came into the services. We had naloxone, which we'd administered not just by ourselves, but by people we trained within the hotels, and hotel staff also agreed to be trained in actually administering naloxone as well. We had sexual health clinics, we had virtual CBT going on, we had all sorts of things that we created to accommodate people and keep them in that accommodation and do something really productive and take that opportunity and take the risks for these most vulnerable individuals who often are excluded from services. And one of the other challenges was language, because around 50% of the hotel population at various stages of this were EU nationals, the largest proportion of which were Polish males and Romanian families, which had come to Edinburgh for begging purposes, and then couldn't return to their own homes because of the lockdown. One of the great successes, if you like, that we had, and virtually in 48 hours, we took 120 people off the streets. The night shelter in Edinburgh, which normally housed people in camp beds, 70 and 80 a night, went from having that number to 2 people attending it, because everybody was brought in, everybody came in from the streets, and everybody was in the accommodation. And one of the really interesting bits for me, and I wanted to highlight this, we talk about sustainability of these things. This project changed policy. This project changed the way that services are delivered in Edinburgh because of the massive successes for the most vulnerable clients that were out there. And I actually asked the current manager in Edinburgh, who took over some of the services I was running at the time, and she said that the last rough sleeping count, only 10 individuals were found. And I can tell you, the year before COVID, it was regularly at 130, 130 plus. So it shows you that the actual progress that we did over that 6 months, and the fact we housed everybody appropriately in accommodation, has meant that it's been sustained, and in the virtual eradication almost of rough sleeping in Edinburgh, which is the worst problem in Scotland. Smoking cessation has been mentioned by other colleagues today. It's a massive, massive problem, public health problem in the homeless population, and they never get to smoking cessation services. We brought those services to them, and the Director of Public Health invested in developing a smoking cessation project with us. It was massively successful. 400, 500 different vapes were circulated amongst the homeless population. 47 people actually got their vaccinations. This is before the COVID vaccine was even discovered at this particular time. But the vaccination people who normally did the schools and the children and everybody else were pretty much redundant at that time, because they were all had no work because of the lockdown. But we motivated them to actually come in and work with us, and they actually gave all the inoculations to every single person. I think it was 47 people in the end received all their vaccinations while they were still in the premises. Homeless policy and practice was changed. There is now a hotel rather than camp beds that actually are the night shelter now in Edinburgh, because they saw the benefits of using hospitality rather with a bit of dignity and a bit of respect for those individuals, and saw the responses that they got from them. And we developed, I moved on actually to develop the first managed alcohol programme in the UK, a residential unit, not in Edinburgh but in Glasgow, which my organisation had ambition to develop. And we learned the lessons from the hotels in Edinburgh, and we developed it on a model using psychologically informed approaches. It also inspired staff. You know, these things it was totally exceptional. Staff went out to do really creative and innovative things. This young man is a support worker who worked with us part-time during the hotel's period, and he saw a massive gap in that we're putting out naloxone in various things, but there's nothing in the community setting. So he's now gone off and developed this. He's a designer by trade, and he's gone off and developed, and I know he's speaking to the NHS in Scotland now, but potentially rolling this opiate reversal kit out to community venues. I just wanted to show this beautiful picture of the various areas of Edinburgh, but also I wanted to show you, this is about lockdown. I have to tell you, it was fantastic. I was out with my street team walking about the streets of Edinburgh. It was absolutely isolated and beautiful, and I'll never, ever see that again. I've just put 3 case studies in here to show you the depth of the difference this has made to people. The first one's a Canadian guy who turned out was in the Canadian Coast Guard when we actually found out who he was in the end. He had been sleeping out for 10 years on the same bench, hadn't moved, had his 40 bags around him, and he had slept there for 10 years, for over a decade. And although we'd been doing intensive work with him for over 6 months, COVID was a catalyst actually getting him to bring him in. And at the time we brought him in, he was suffering from rat bites, trench foot, he had chest and breathing difficulties and still had mental health problems. But he's now living safe and well in supported accommodation and has sustained that ever since. The second individual was quite a famous and violent man in Edinburgh. And when he came to us at the Cairn Hotel, we were advised not to allow him to stay in accommodation because of the risks attached with this gentleman. In fact, his social worker gave me 3 pages of A4 risks about this individual and why we shouldn't take him into the accommodation, his own key worker. But we did bring him in and we gave him the opportunity, and I can tell you that transformed that man's lives. And it also transformed some of the thinking of some of the social work department who had given up on this man. He transformed his life. He's now managing his drug problem quite well, and he did get housed by the Edinburgh Council in the end because of the developments. And the last one is a Polish individual who was ex-Special Forces and had been accessing our open access service for a long period of time. He had quite severe alcohol and psychological problems. But the accommodation and the responsibility he started taking on is he took over the maintenance of the building. We had 3 Polish men who did all the maintenance and all the joinery work within the place. And they started cleaning up the streets and showing a load of social responsibility for the neighbours and people who had to put up with all the homeless population suddenly being on their doorstep. And he also held the record for the 5K run, which we developed as part of our social programme there, for 27 minutes, which I can get nowhere near these days, unfortunately. But one of the big things about bringing people into the accommodation was it wasn't just about bringing them off the streets, it was about taking those opportunities, taking those risks in order to develop those individuals. And for the last month, July and August, we brought in the School of Hard Knocks, which is a social enterprise project that does social and psychological interventions with people, and sport diversion projects, to build esteem and leadership and to allow people to move forward in their lives. And that was, again, transformational for some people. I have to say, this isn't a photograph from there because we were trying to keep people socially isolated. So they didn't use rugby on this occasion, but they used other methods to bring in fitness and well-being and psychotherapy was also part of what they delivered. We gave hundreds of phones out to connect people and prevent social, or to promote social inclusion, both at the Cairn and Hotel and at the Holyrood Hub. And the Department of Work and Pensions actually funded all the employability programme because they saw the benefit for the homeless population. What did we learn? And I've just put this in really simple terms. We learned that trauma and psychologically informed approaches, they really do work. You know, we talk about it and we look at the research, but they really do work if you do it properly. Staff commitment, skills and innovation were the absolute key to retaining and doing really proactive work with individuals. Quality counts. dignity and respect for those individuals is what we should be showing them, and that's what the hotel staff and the hospitality staff did. Maslow got a lot right. If you feed people really well, you give them really good accommodation, you know, they will do amazing things for themselves. No risk and no reward. Sorry, I was just going to mention this book, and I'm not being paid to mention this book, by the way. This is a fantastic GP in the city of Edinburgh called Gavin Francis, who writes lots of books. But he wrote this book on intensive care as a GP in Edinburgh at the time, who was dealing it from a general practitioner's perspective. And he also worked at the Access practice, the homeless addictions practice at the time as well. And he visited the Cairn Hotel. And he gave us there's a whole chapter based on what he saw at the hotel. And the comments that he was making, that intensive care wasn't just about health services. It wasn't just about addiction services. It was about the third sector actually delivering intensive care in a multi-agency collaborative way. And a bit of food for thought. This is the first day of this conference, so I was thinking about what do I want to try and get by doing this wee talk today. And I think we really need to find ways of continuing to inspire our governments and our politicians and society and the managers that are young managers that are coming through now to take risks and reap the rewards and support them in doing that and taking those risks. And I say again, the Edinburgh project has changed Scottish government policy. And that's a really powerful thing. And the 28th of August was the last day that we closed the Cairn Hotel. But every single person that came into the hotel was housed appropriately and had individual support and housing plans and were placed in appropriate accommodation before they left. And I just wanted to say a final thing about Cairn and his staff and the hospitality staff. Without them, none of this would have been possible. And we learned lots from them and their empathy and their approach to dealing with some of the most complex individuals which were in our street population at the time. Finally, we don't do these things for awards, but my organisation at the time was really privileged to win Charity of the Year in Scotland as a result of the fantastic project, not just in Edinburgh, which I was leading on, but our Glasgow project as well, which did very similar work in the Glasgow area. And I really like to thank you for the opportunity of coming here today. I wish you a good conference. And if anybody would like to know more, I'll be here for the next 2 or 3 days. It was lovely to meet you all. Thank you.
Thank you very much, Rankin. Now going to present our final presenter before we move to the opportunity for some questions and some discussion. And we're looking to the city of Lisbon now. Maria Bento Camargo has a master's degree in forensic psychology and social exclusion and has been working in the field of harm reduction for the last 9 years. She's worked on housing first methodology, outreach teams and research projects and has experience of interventions with vulnerable populations, particularly people who use drugs, people who experience or have experienced homelessness, asylum seekers, refugees and migrants. Maria participates in several working groups with other organisations and public institutions aimed at supporting vulnerable populations. Maria.
Hello, good afternoon, everyone. I would like to thank the Global Health Platform Network for inviting Crescer and giving us the opportunity to share the work that we have been doing. I would also like to leave a special thanks to Kasia. Just to quickly put this into context, Crescer has been working in the field of harm reduction since 2001. With people who use drugs, with asylum seekers, refugees and migrants, and with people who are experiencing homelessness, which is the focus of our presentation today. As I'm going to speak in English, which is not my language, I'm going to read so I don't get lost. So, With the COVID-19 pandemic, the problem of people experiencing homelessness has taken a greater dimension. Unemployment and poverty scale up, increasing the number of people experiencing homelessness. Recent data shows that during 2020, 356 people were chronically living in the city, in the streets of Lisbon, and 140 people, new people were experiencing homelessness. New target groups emerged, such as people who were recently released from prison or lost their jobs, and families in risk of eviction. People lost informal sources of income, and here it's important to highlight that in Portugal, social income is around 200 euros per month, and for that reason, informal sources of income are very significant for people who are experiencing homelessness. At the same time, the access to social support has also become more difficult. Informal sources of support, where people normally went to take a meal, like the restaurants or civil society organizations, or to take a bath, like the public bathrooms, all that structures were closed, increasing the demand for food, water, and hygienic supplies. The access to healthcare has become more difficult to the general population, but in cases of unhoused people with comorbidities, physical and psychiatric problems, these had a greater impact on personal health. Access to drug or alcohol treatment is a longer process due to testing and isolation demands, which does not allow to answer in real time to the needs of people who are ready for immediate treatment. Due to difficult access to money, population with severe alcohol consumption are at greater risk of withdrawal, which could be a life-threatening situation. Stay home, which was a slogan widely disseminated by the government, was not an option, and people were more exposed to the virus, depending on outreach workers to articulate with health services in suspected cases of COVID-19, to support clients through test procedures and provide transportation, to find temporary housing solutions and deliver goods, medication, methadone, naloxone, ascetic material for people who use drugs when necessary, and all the things that people were needing. The need for social distancing minimized interactions and increased the social isolation of this population. What have we done? Considering the profile of our clients, vulnerable people who are experiencing or who have experienced homelessness, most of whom with health conditions, that is COVID-19 high-risk group, and the necessity to continue supporting them more than ever, Crescer has adapted its daily activities. A contingency plan was designed and implemented in March 16, previously to the state of emergency declaration, to reduce the risk and take account of possible future constraints in human resources availability due to illness and or prophylactic isolation. Restaurante is a social business implemented by Crescer in 2019, and its main goal is to train and include in the labor market people who have experienced homelessness. It is an employment project entirely designed to meet the needs of people who are homeless. This restaurant is located in the city center, in one of the most expensive areas, and has as its ambassador a very well-known Portuguese chef. Just like all the other restaurants, ours had to close due to the pandemic, but it never went out of business. On the contrary, most organizations that distributed foods on the street were volunteer-based, and with the pandemic, these organizations ceased or greatly reduced their activity. In this scenario, the trainees of our restaurant, people who were previously homeless, set out to cook and start distributing food to those who were now living on the streets. And so the restaurant started cooking up to 600 meals a day to distribute on the streets and in shelters. This was first our, when the COVID, or when the pandemic turn the restaurants off to the general public. We started to do this by our initiative, but a few months later, and we are still working, we are still doing this. It was our initiative at the first time, but a few months later, the municipality of Lisbon, they made a contract with us in order to help us keeping this support to the population that were on the streets and also in emergency shelters that were created at the time. And this effectively demonstrated what we often find difficult to communicate to policymakers, that these people also have skills like any other. And this response even reached places on the street where the volunteer teams didn't go, places that our trainees knew from the time they were living on the street themselves. Despite being greatly affected by the pandemic, this project managed to employ 15 people during this period, not in restaurants, but in several other areas. And the most ironic thing for us about this response is that it was the people who were previously homeless who took the first step to support those on the streets and worked daily, non-stop, to get food to the streets. Another project where we had to adapt our daily activity was at É Uma Casa Lisboa Housing First. And for those who may not know what Housing First is, it is a methodology that was implemented for the first time in the United States, and that aims to be an effective answer for people living in a chronic homeless situation. Housing First provides immediate access to independent, permanent, and individual scattered site apartments, combined with off-site support and community-based services. It offers people who experience homelessness a place of their own without preconditions. Based on harm reduction approach, staff meet people where they are at and start a support process from that point. In this approach, tenants are supported toward recovery, being encouraged to make their own decisions and drive the process themselves. What we have experienced is that without any impositions, people significantly reduce their consumption, adhere to health services, and 87% of the cases do not return to a homeless situation. Once again, COVID-19 pandemic brought some challenges to our Housing First program, and we needed to adapt ourselves. Goods and medication were delivered to high-risk tenants in lockdown, prophylactic isolation, and positive cases. In a normal situation, people's access to community services is always promoted in this methodology. Staff articulated with opioid substitution therapy programs to provide methadone home delivery and, in some cases, to adjust the doses for those who used to use drugs in parallel but were not being able to, because of COVID, they were not allowed to leave their houses. The staff team home delivered aesthetic material to injected and smoked drug use when necessary, and in cases of people with severe alcohol consumption, alcohol was provided when needed. Naloxone continued to be made available for tenants, and one aspect that had a big impact was the temporary suspension of tenants' meetings, which happened in a monthly basis. And that compromises the way that tenants engage with the program and take advantage of it. These meetings are moments to exchange experiences, approach common difficulties, develop social tools, and a greater sense of advocacy. Crescer also took this opportunity to present a project for a managed alcohol program, which, like Rankin explained, combines housing with management and supply of regular doses of alcohol as a harm reduction strategy. This project has been approved. We presented it to the municipality of Lisbon and also to the government, and it was approved in 2020, but however, the place for its implementation, it's not available yet, so it didn't start. People, like I said, people were asked to stay at home, and that was one of the Government was always asking people to stay at home. It was a national slogan at the time. But thinking about this population, the only ones who were able to stay at home without risk of contracting the disease were housing first users who had non-shared houses. There was also other responses, a number of responses created in the municipality of Lisbon and also at national level that promoted greater security for vulnerable groups, mainly for people experiencing homelessness. And the municipality of Lisbon invested in 260 more housing first apartments in the city in just 1 year. The pandemic helped policymakers realize that housing first is an efficient and effective response to these situations. People could stay at home, taking no risks. Emergency centers were created to receive people who were sleeping on the streets. The staff teams working in those centers were composed by professionals from several organizations that already worked with this population on the streets, and volunteers. The spaces were adapted so that they could welcome all people, people with pets, couples, transgender people, and also people under the effects of psychoactive substances. Also, a government document was released with guidelines for the administration of a medication protocol for homeless people with alcohol-related problems. So this measure was aimed at preventing serious alcohol withdrawal syndromes as well as life-threatening situations. The government considered it urgent to provide these citizens with free supportive therapy. All the structures that received people with alcohol abuse, even if they didn't have doctors working on the structures, they knew the type of medication that they had to administer. Facilities of the national health system, both in general medicine and also in the area of addictive behaviors, have created a response of consultations by video call. Along with this response, Crescer created in its facilities conditions so that people could access these medical consultations by video call. In a transversal way to the general activity of Crescer, we always try to develop advocacy, and this was a period when we focused a lot on homeless people due to the aggravated condition of vulnerability they are in. And we focused on the urgent need to eradicate chronic homelessness and to promote access to housing in order to guarantee the dignity and security of all. In cost effectiveness related to housing first, evidence-based methodologies, and we also wrote a document addressed to the government and the task force that was responsible for the operationalization of the national vaccination plan against COVID-19 to prioritize the vaccination for homeless people. And what have we learned? The partnership between outreach workers and healthcare services improves testing and adherence to treatment. The use of technology brings healthcare services and professionals closer to vulnerable clients. The pandemic proved something that we have been saying for a long time, that the line between being homeless and not being homeless is very thin. People who had jobs and their lives organized, but in more precarious situations, became homeless from one day to the other. In this sense, we believe that it is increasingly important to create prevention policies. Community-based services with a proximity and relationship-based approach are the most efficient health responses for excluded populations. And the practice of inviting policymakers to visit our projects and promoting their involvement and direct contact with the beneficiaries has allowed a real knowledge of the responses and, in a pandemic situation, led to a greater investment in innovative responses, as was the example of Housing First in the municipality of Lisbon, which went from 80 to 340 houses in the city of Lisbon. Thank you.
We'll now have the opportunity, if you've got questions, to ask any of the presenters. The microphone there that I'm pointing at is the one that you'll come to deliver your question. And if you wave at me, I'll try to pick you out from the audience. But we've got some questions that have come online. And I'll start off, actually. We have a good starting point here from two separate people, actually, Francis and Sasha. And this is to everyone, really. Really, what surprised you most? What of your experiences in setting or running services during the COVID pandemic experience surprised you most? And yes, you have the microphone and are ready to go.
Prowadziliśmy... Czy mnie słychać? Słychać, tak?
Yeah.
Prowadziliśmy przed COVID-em, jeszcze w marcu 2020 program,
we've launched a program and we continue program, so Care program, so there were like 15 people using that service per day, and we are providing accommodation for those people. So, and when we had the aggravation of the situation in March and April, so we thought that it's a good idea to suggest self-isolation for these people, so we just packed like many people in our hostel for 15 people, but people agreed to be subjected to that self-isolation, and we intermediated for us to collect methadone from their substitution program, and I think that it was the first change of our daily routines, and our street workers really were involved in that. So we had this outreach program, so they collected substitution drugs from the various programs and they delivered them to our clients in isolation. So they were really packed out. It was 150 meters. It was like 155 meters to be precise, square meters to be precise. There were many people in that, and there were lots of rooms that they didn't have any access to, and that was a huge problem, which generated some derivative problems, such as violent behaviors, or maybe, or there were different tension within the group. And another thing that we had to resolve was providing nutrition and feeding that group. So at that time, we didn't have any resources to provide food. Well, they have to organize the food by themselves. So we had some resources for small treats, such as coffee, tea, or instant soups. We didn't have any facial masks even, so we didn't have any funds for these purposes. And so we managed to change or revise contracts that we signed with our sponsors to be capable of buying some protective resources, personal protection resources, such as masks, instead of syringes. And the most difficult problem we have to face was that our customers were people who were using great many different substances. Apart from methadone, they also used another substance which is broadly used by our groups, benzodiazepines, which were prescribed by physicians, practitioners, not the physicians, of course, but some other physicians. So we had this doctor shopping formula used, and we have a methadone, which was used by nearly 70% of our groups, and obviously alcohol. That was a common problem for all. So having this packed up situations, lots of people, violence. So we had to eliminate methadone and to eliminate alcohol, and we gradually managed that. We cooperated one of the detoxification branches, but they really returned to the inpatient facility later on, but there was like a couple of months of our effort aimed at eliminating alcohol and methadone from our hostel. And then there was another problem that we did not manage to solve, was injection of methadone. Injection of methadone, this happens. Of course, it's not an overall problem. These are just minorities, but it happens. Well, I think that the discipline within the group has improved lately. I think that the COVID was a stimulus for them. They got like a brand new energy because of that, and they were committed in creating, organizing our new facility, entertainment facility in Augustów. We didn't have enough resources for refurbishment and redecoration of that development, but these patients were capable of helping us out and pursuing some sports activities, entertainment activities, and I believe that it really worked. So now the group has changed. So it's a completely different group than before COVID pandemics. And we also managed to open that readaptation apartment too. We have 5 people who are capable of joining the society, rejoining the society. They are independent. They can manage their businesses independently, manage their lives. And I believe that they will soon leave us and they will transfer to their own apartment, or they will be also provided with some social support. So there were some, there is some silver lining around COVID, of course, apart from hard work too. But COVID pandemics also showed us that there are some different, still new readaptation possibilities. There's lots of more to be done.
Thank you. Emma, I can see you there by the wonders of technology. Was there anything you found surprising, what worked in London? I think we may have a technical problem on the sound. No?
Can you hear me? How is that?
Thanks, Emma. Loud and clear.
Are we good? Okay, sorry. Yeah, I would say 2 main things. So for colleagues who are working in homelessness services or in drug and alcohol services, just the incredible capacity for people to change is often really misunderstood. And, you know, we had people who we've seen over the course of the last 2 years that I think had been written off by just about every service under the sun. So, you know, they'd been through 10 years of prison, homelessness services, drug and alcohol services, health services, etc., were deemed to be, you know, sort of unsavable, and people really surprise you. So, you know, we had some very significantly unwell people who actually did very well on the basis of the pandemic. So yeah, don't give up on people would be my first point. And the other thing that I suppose surprised me a lot was the overall acceptability of electronic cigarettes and vaping devices within the homeless population. There was a big concern, I suppose, before we went into this, that they would be traded or used as currency, or we would, you know, give out thousands of vapes for them not to be used at all, and they'd go missing or have fallen off the back of a truck. And that didn't happen at all. People became actually quite proud of their vapes. About 50% of people stuck with vaping post moving on to alternative accommodation and reduced their tobacco consumption. So those were my 2 main points.
Excellent, thank you. Maria, well.
I think that one of the most surprising things that Emma already talked about it also was the capacity of people to adapt themselves. I'm talking about our beneficiaries, the capacity that they had to adapt themselves to all the new rules, all the new things that were imposed to them from one day to another. They also had to adapt to our adaptations and to all the things that we changed. Another thing that I think that worked well, it was at least in Portugal, I think that the NGOs are always very competitive, and I think that during this period, there was a surprising way of working together that was that went very well.
Thank you. Are there any questions? If people got questions, please come up. Yes, over to you where the microphone is.
First, I want to congratulate every one of you and the great stuff you made in each of the countries. It's really amazing, your job. I just want to say something. I'm very concerned. I'm from Chile. I'm advocate on vaping. I'm very concerned in the case of Poland that only one of the person that was in this situation accept the e-cigarette as an option. Badly, we are fighting with a lot of misinformation on vaping, and I think in the case of Poland, that's even worse because you have a very bad legal statement that misunderstand information with publicity. The only thing that I can offer in some way is to help you to inform that people. I'm staying here in Poland for a long time now. So I will gladly help you in informing the people about e-cigarettes. People need a lot of information, especially in the countries that have a very bad position towards this low-risk option. And I think that's why we see a lot of difference with England or Scotland or Portugal that were using these devices with good results. I'm very happy about that, but I want to congratulate you again because it's awesome what you have done. It's very, I don't know how to say it in English, sorry, I speak in Spanish, but it made me really happy to hear from you that 86% of that people didn't went back to the streets, same in Scotland, same in England. It's awesome, and just want to congratulate you and offer you the hand to inform them. We can talk and find a way to help you. And that's it. Thanks for your work.
Okay, thank you. Is there a very quick response or perhaps?
Proszę Państwa, ja też jestem poniekąd ofiarą nikotynizmu. W okresie COVID-u zacząłem palić po 25 latach niepalenia. I starałem się, i bardzo szybko przeszedłem z zwykłych papierosów na papierosy. Trochę własnym przykładem zmieniałem te różne urządzenia, zachęcałem.
I encouraged people to smoke this kind of device. I let them try it, but in Poland, the problem is mainly in our people who are in charge of the programs for social readaptation, and we have to target them with the mission of education, because the very idea of harm reduction is very suspicious to them. And right now, as we have the government of people, which has a negative attitude towards the harm reduction concept, the society is suspicious towards the e-cigarettes, and those in charge have a problem with it, and they don't know how to approach it. In turn, I've taken part in the meetings of the council, and this form of harm reduction changed the life into more comfortable life. Those people who are in charge of this program connected with providing care to homeless people. It would, if we had resources to buy those devices, probably the things would look better.
I'm very conscious, and I know I've got questions online and questions in the room, but it's also very close to when you get a cup of tea or coffee. And obviously with an online audience, we have to stick to time. We don't have the flexibility that we once had. So I'm going to ask people who've got questions to take them up directly with people afterwards, perhaps during the tea break. People online, please put them in the chat and we'll try to get back to you. But it is my job really to ask you to join me in thanking all our presenters for their presentations and the interesting topics they brought up. I think just a couple of points that have really stuck with me is the value of engaging the clients or patients, the individuals, and what they can bring to the work, and you know, the importance of dignity and security, and you know, the fact that we have tended often, I speak from my own experience, people have often been written off as too hard to reach, not prepared to engage with services. And if there's one thing we have found out in the recent period is that actually people who can be quite surprising in how much they can make progress if you give them the right opportunities. So please join me in thanking the presenters. Thank you. We have a 15-minute break now. Please be back in your seats at 5 o'clock. Thank you very much.
Can we start again, please, people? Because we've got people online and we've got to keep to time as a result of that. So my name's Paddy Costill, and it's my pleasure to have the responsibility for introducing the final sessions for the day. I'd like to thank Kasia and the rest of the people from the Global Public Health Network for inviting me to do this. It's a very special occasion involving some people who are still with us and some who aren't, but all of them are people who have had a tremendous impact on my career to date. We're going to start with the Allison, Chesney and Eddie Koloran Memorial Lecture. Eddie and Allison were both colleagues and close friends of mine. They died within 6 months of each other in 2006. They were leaders in the field of harm reduction and are still much missed by friends, family and colleagues alike. The memorial lectures were established in 2010 as a living tribute to their memory and have been delivered by high-profile international experts ever since. The 12th lecture this evening continues in this tradition and is going to be delivered by Professor Alex Stevens from the University of Kent in the UK, who I think is joining us online. I'll wait till Alex appears. Hi, Alex. Alex, like me, had worked with Allison and Eddie. His work developing and coordinating the European network of drug and HIV services in prisons was also part of the genesis of the City Health Project and the Global Public Health Network. Given the wide-ranging focus of his work in criminal justice systems, particularly in relation to drugs, provides a unique perspective for him to share his thoughts on changes, both positive and negative, over the past 25 years. I find it hard to believe it's 25 years since he and I worked together, but I would actually venture that I was the person that gave him his first proper job. And now look at how the roles are reversed. So I'm sure you're keen to hear more from him rather than from me. So without further ado, I'll hand over to Alex to deliver the lecture.
Thanks, Paddy. Thanks for that introduction, and thanks for giving me my first job in the drugs field. It's an absolute honour to give this lecture in memory of Allison Chesney and Eddie Koloran. As Paddy says, my first job in the drug field was working with Paddy for Allison Chesney when she was the head of clandestine drug projects at that time. Working with Paddy, Mike Trace, Paulo Pertica in the then Prisoners Resource Service was a huge privilege. I learned so much from them. And it started me thinking about many of the themes that have informed my career and informed this lecture today. One of the stories that is told about Eddie Koloran in his obituary by John Podmore is about him breaking into his headmaster's office at school and breaking the canes that were used to beat boys and to punish them. And what I'd like to do today is ask a question inspired by Eddie and Allison's work, which is, what happens when we break the cane of criminalization? The dominant mode of drug policy across the United Nations is, and it's single convention on narcotic drugs, which requires that countries have in place systems to punish people for making various uses of substances. And we're seeing movements away from that in terms of various alternatives to criminalization. And we hope that we can break this cane of punishment and have these alternatives in order to reduce the pains of punishment and increase the support we can provide to people who have problems with their drug use. And three ways we might do that include depenalizing drug possession, diverting drug offenders from the criminal justice system, or even decriminalizing the possession and use of drugs. A fourth way is legalization, which I won't spend much time on today, but I'll focus on these alternatives to criminalization of possession and use rather than models for supply. Now, these offer great opportunities, as I'll discuss, but there are also dangers here, as I have seen repeatedly in my career over the last 25 years, of merging treatment and criminal justice systems so that we might indeed end up providing more punishment to people who use drugs via what another intellectual mentor of mine, Stan Cohen, has called these three mechanisms: net widening, or increasing the size of the net, increasing the number of people who are drawn into some sort of penal control; or mesh thinning, the process Cohen describes where it becomes harder and heavier to be in the net of control and harder to get out of it because the gaps in it become smaller and smaller and the mechanisms of control become tighter and tighter. And there's this third danger that Stan Cohen talked about in his book, Visions of Social Control, where he talks about social control entrepreneurship and the temptation of people who, perhaps with great intentions, set out to work with the state to reduce the use of punishment, but end up through their willingness to capture larger shares of the market of welfare and control, being entrepreneurs in the process of social control. So my lecture today will be looking at these forms of alternative to criminalization and whether we're achieving the aim of supporting and not punishing, or whether we're increasing the levels of social control we're applying to these people who are being caught up in our nets. Let me find where I can move this on. I hope I can move it on there. Yes. So before I'm going on to describe these examples of ways of alternatives to criminalization for people who use drugs, I'd like you to consider these questions that Stan Cohen poses to us. And as we're going through this list of examples I'm going to display to you, I'd like you to be asking yourself these questions. With these alternatives to criminalization, what is the size and density of the net? How wide and strong is the net we're throwing over people who use drugs? The second question about identity and visibility. Can we see the net? Are we recognizing the elements of social control that we retain in these alternatives for criminalization for people who use drugs? Can we recognize it for what it is, or are we fooling ourselves that paternalistically we're not replacing one form of control for another? And the third question, penetration, he describes it as, how does the net affect the people and processes around it? Do the ways that we're providing alternatives to decriminalization do something to the system that means that it is reducing the amount of punishment, or maybe it's increasing the control we're placing on people's lives for whose activities we may not agree with? So I'm hoping you'll ask yourselves these questions as we look at these alternatives, which I've categorized in this way. This is based on some work I did with Caitlin Hughes and colleagues for the Irish government, where we classified the alternatives that were being used in different countries for dealing with people for simple drug possession. So that's drug possession without intent to supply or evidence of production or distribution of those substances. And we classified these alternatives in three broad categories: depenalization, or the decision not to apply the laws that are in place around possession and use of these substances; diversion, or the various mechanisms that might be used to divert people away from punishment and towards treatment or welfare services; and decriminalization, which is the removal in law of penalties of the criminal offence of drug possession or use. Now, that's the top level of this taxonomy, these three different categories. But within the two of those categories, we find subtypes. So, for example, within the category of diversion, this can be done either in a de facto manner by changing the practice of police or prosecutors without changing the law, or it can be done in a de jure way by actually changing the law to allow or mandate the police to divert people away from punishment. And within decriminalisation, we found 3 different categories. So on the right-hand side of this diagram, you'll see the fullest form of decriminalisation, which is decriminalisation with no sanctions. This means we remove the penalty, we remove the offence of drug possession or use from the criminal law and don't replace it with civil penalties. But there is a category, decriminalisation with civil sanctions, where that criminal offence is replaced with a civil or administrative offence, and the criminal penalties are replaced with civil or administrative sanctions. There's also a hybrid form that you see in the middle of this bottom row, where decriminalisation, so the removal of the criminal offence from the criminal law, is accompanied with diversion. And so that's the example most famously exemplified by Portugal. And I'll get to that in this list that I'm just about to show you of the different countries and places that have implemented these different types. So starting with depenalisation, as I said, this is the use of discretion of the police or prosecutors without changing the law to avoid inflicting the pains or punishments or criminal records of this criminalisation process that we're trying to avoid. This was done in Denmark between 1969 and 2004, where the arrest and prosecution of people who were found in possession of small quantities of controlled substances was replaced with police issuing warnings instead. This has also been done in my own country, in England and Wales, since 2004. In 2004, the police service introduced what were known as the Cannabis Warnings. This gave the police the opportunity to, instead of arresting, cautioning, convicting people for the possession of small amounts of cannabis, people could be given a warning right there and then on the street, which was just a written ticket that said you have been warned for your possession of small amounts of cannabis. This was in place for several years, but has more recently fallen into disuse as the police in England have been making more use of what's known as community resolutions, a broader mechanism for just dealing with an offence on the street without having to arrest or take someone to the police station or give them a criminal record in the form of caution or a further charge. Now, these are, would seem to be, and indeed are, useful mechanisms to avoid the harms and costs of arrest. But we also did see some evidence in England of this net widening effect. So this is a graph taken from some work carried out by Mike Shiner of the London School of Economics back in 2015. And he looked at the official data on the use of these warnings compared to the cautions that were the alternative sanction for these low-level cannabis offences. And the middle grey line, which is the number of criminal cautions that were given for cannabis offences, indeed did fall in 2004. So fewer people getting a criminal record for cannabis possession. But what you see in the big black line that increases so much is that because this was a much easier way for the police to deal with a cannabis possession offence, and because the police were at that time given targets for the number of offences they should bring to justice, so how many offences they were basically detecting, this actually led to an increase in the numbers of people who were given some sort of formal interaction with the police. We have research, for example, from Hamish Warburton and colleagues that showed that prior to this, it was quite common for police simply to dispose of cannabis that they found on people without going through any sort of process whatsoever, in order to avoid spending about 10 hours or so processing people, taking them to a police station and taking them through the criminal justice system. What the cannabis warning and subsequently the community resolution allowed the police to do was to increase this net of control by getting people into their databases for the use of cannabis, even though people were not getting such a punishment in the form of a criminal record with the caution. Our first example here of net widening. The second type in this taxonomy that I showed you is de jure police diversion. So again, de facto police diversion. Again, no change in the law, but changes in the practice of police and prosecutors in order to divert people who are found in possession of small quantities of drugs away from charge and prosecution and towards some form of therapeutic or educative intervention. And there are several examples of this around the world, including in Australian states. In England, it's currently available in at least 4 policing areas in Durham, West Midlands, Thames Valley, and Bristol. And under these schemes, we have seen consistently in the countries and places where it's been done, reductions in arrests and reductions in the costs of these criminal justice processes, along with less damage to job prospects and relationships. We know, for example, that criminalizing people damages their job prospects. Criminalizing people damages the relationship they have with their families. And when we can avoid doing that by not giving them these criminal records, and perhaps by diverting them to more therapeutic or educative forms of intervention, we are reducing the damage we do to them. Working. So if somebody else could move this forward for me, thank you very much. I'm providing examples here of both this beneficial and the potentially net widening effect from a randomized trial that was done of what's known as the Turning Point scheme in Birmingham. This was a randomized trial that randomized people who were caught for low-level offences, including drug possession. And they were randomly allocated to either go through the normal prosecution and court process or to be given a diversion scheme, which was known as Turning Point, which gave them an assessment and referral on to educative and therapeutic interventions. And you see 3 different outcomes from this scheme as shown by these 3 graphs. On the left, the first graph, graph 1, we saw reductions in the severity and amount of crime committed by people who were randomly allocated to be diverted away from prosecution compared to those who were prosecuted. What the evaluators used here was a measure of the severity of the offence multiplied by the number of offences, which gave them an overall measure of criminal harm that was done. And the level of criminal harm in the group that was randomised to be diverted was 36% lower than it was in those people who were treated with prosecution as normal. In the second graph, we see quite an interesting phenomenon, which the evaluators called the consequences of actually being caught. And these consequences actually increased in the group that was randomized to be diverted. Because you see on the left-hand bar in the second graph that those people who are prosecuted, about 30% of those people, because of attrition in the criminal justice system and the way that many cases don't actually get to court, many of those people didn't actually receive any form of consequence from the offence that they committed. Whereas because of the immediacy of the diversion, people didn't have to wait for a court date, didn't need to meet such standards of evidence to be invited into the programme. There was more people in the Turning Point scheme actually received some form of consequence, even though it was not a very harsh consequence, than if they had been prosecuted in a normal way. In the third graph on the right here, we see a comparison of the costs, and we see much higher costs associated with the usual form of prosecution than diversion to these interventions. So a reduction of about 45% in the cost of dealing with these offences from diverting people. So we see here a reduction in crime, a reduction in cost, but an interesting increase in the proportion of these people who actually receive some form of consequence. So I'm inviting you to consider Cohen's questions and think whether this is a form of net widening and whether it's actually a good thing that we're doing more consequences to people, or that we're actually increasing the net of social control to which people are exposed. Another form of diversion is de jure diversion. Here is where the law is actually changed to allow or mandate police to send people to treatment or assessment instead of the usual prosecution process. And we see similar results to for diversion, whether it's de jure or de facto. But an interesting difference between dealing in a de jure legal manner compared to the de facto sort of practical manner is that this doing it in the law relieves the police with less discretion as to who or who not they are going to include. And so we see in many countries, including my own, very high disparities between ethnic groups in terms of who gets policed for drugs. In my country, it's you're about nine times more likely to be stop and search for drug offences if you're black than if you're white, and that's commonly experienced across many countries. And so when we have discretion in the system, because of the existence of institutional racism, that can be disadvantageous to some groups, including minority ethnic groups. But apart from that, we see similar effects for de jure compared to de facto schemes, including, for example, that we see reductions in the use of police time, better outcomes in terms of not damaging people, not giving people damage to their employment and accommodation or relationship prospects because of this criminal record. And we also saw, for example, in the evaluation of the South Australian cannabis expiation notice, which was a small fine instead of a prosecution, that there were similar trends in cannabis use across the states and places in Australia that did or did not have such a scheme. But there was a net widening effect. So because it was easier to give people this expiation notice than to arrest and prosecute them, there was a 2.5-fold increase, 2.5 times more people getting some form of recorded response from the criminal justice system to their cannabis possession than was previously there. And this had the added effect in the South Australian scheme, because it involved getting a fine. This expiation notice included you had to pay a fine to have this expiation. And many people either didn't or couldn't afford to pay this fine. There were increases in the number of people who were imprisoned, even though they were being imprisoned for failure to pay the fine rather than directly for their drug offence. The next type I want to discuss is decriminalisation with diversion. This is where there is a formal legal de jure decriminalisation, a removal of the criminal offensive possession from the law, as occurred in Portugal in 2001. But there may be still administrative sanctions, such as small fines, or the removal of driving licenses or licenses to carry firearms. So Portugal is the best known example. Oregon has also recently moved to a similar sort of diversion approach to decriminalisation. Let's have a look at some of the evidence from Portugal. And let's remember, when looking at this evidence, that Portugal didn't just decriminalise the possession of small quantities of all drugs, not just cannabis. It also invested heavily in welfare reform. It introduced a guaranteed minimum income and invested in harm reduction services, expanding the provision of opioid substitution treatment. So these effects I'm showing you are not just of decriminalisation. They're of a systemic approach away from a criminal justice approach and towards a public health approach. But by adopting that, Portugal saw substantial reductions in the proportion of people in its prison population who were there for drug offences. And if we compare that to a fairly stable or even increasing picture in the rest of Europe, this is a good outcome from decriminalisation. Fewer people in prison, less overcrowded prisons, better conditions, better chances of rehabilitation for those people who are in prison. But the main focus of Portugal's public health approach was health indicators, a crisis in the late 90s of HIV infections being transmitted between people who inject drugs, and there has been a substantial and sustained reduction in the numbers of people who catch HIV from injection drug use since this public health and decriminalisation approach was introduced in Portugal. There was also a substantial reduction in the number of people who are dying with drugs. So the orange line here is the number of drug-related deaths in Portugal. We saw a substantial reduction immediately after the introduction of this decriminalisation and public health approach. Unfortunately, in more recent years, we're seeing that number creep back up, but still nowhere near the average level of the European Union, and still nowhere near the huge and horrific increases we've seen in the numbers of people dying with drugs in the United Kingdom. And we should also bear in mind the views of people who use drugs in Portugal, as reported by the International Network of People Who Use Drugs in their report, Is Decriminalisation Enough? In that report, they report that people who use drugs are still being subjected to stop and search by the police. It hasn't removed entirely the criminalisation and stigmatisation of that part of our population. Those people still occasionally experience violence from the police, still stigmatised for being drug users, even if they're being seen as sick people rather than criminals because of the public health approach, still exposed to an unsafe, uncertain drug market because this decriminalisation doesn't deal with the illegal market. In fact, it leaves that market in the hands of organised criminals. And so in this report, the International Network of People Who Use Drugs argues that decriminalisation in Portugal is just a first step, an incomplete and partial step towards the fuller decriminalisation and legalisation of these substances. Another form of decriminalisation, which is the most common form in America, but is also the form of alternative that's been in place in Italy for many, many years now, is replacing the criminal offence of possession with a civil offence and civil sanctions for that. So in many states in the USA, for example, since the 1970s, the possession of about an ounce of cannabis has been met with civil fines rather than criminal punishments. Now, this does have the advantage of reducing the numbers of people who are arrested and then sucked into the criminal justice system for their use of cannabis. And in a similar way to legalization. So here we see 3 graphs taken from a study of the effects of different drug policy reforms in states that have or have not either legalized or decriminalized possession of cannabis compared to those US states which have kept their prohibitionist stance intact. And we see in both legalization states and decriminalization states substantial reductions in the number of people arrested for cannabis-related offences. And interestingly, we see this effect being especially beneficial for people who are classified as black, because those are the people who are most exposed to the harms and pains of criminalisation of cannabis possession, and those are the people who've seen the greatest falls in the numbers of these arrests, even if it remains disproportionately that it is black people who are still facing the brunt of punishment for cannabis offences compared to white people. But there is still what I would call residual criminalisation in those states that have decriminalised the possession of cannabis. So we still see punishment and imprisonment for non-payment of fines, as we saw in the South Australian example. We still see, therefore, continued class discrimination in the response to drug possession, because poor people are less likely to be able to pay these fines. It is them who are most likely to end up being imprisoned for non-payment of fines, whereas more wealthy people can just treat these fines as a tax on their enjoyment of these substances. We also see the use of punishment for related offences. So many years ago, cannabis had already been decriminalised in New York, but that didn't prevent a 10-fold increase in the number of people who are being arrested for marijuana-related offences between 1997 and 2007, because it was still a criminal offence to have cannabis on public view. So when the numbers of police officers were dramatically increased in New York, and they went around telling people to empty their pockets, when people emptied their pockets and made that cannabis visible, that was then committing the offence of having cannabis on public view. So even though cannabis had formerly been decriminalised, these other offences related to cannabis were still used to increase the criminalisation and punishment of people who used cannabis. We also see an interesting, sort of parenthetically, I would say, we see an interesting difference between legalisation and decriminalisation in its effects for young people. And these graphs show us that legalisation might not be particularly effective in reducing the punishment of young people in particular, because legalisation is normally done for minors only, people under 21 usually in the United States, whereas decriminalisation is normally applied to all age groups. And so we've seen in the United States larger reductions in the arrest of minors under decriminalisation than we have under legalisation. Now, the final form of decriminalisation I want to talk about is decriminalisation with no sanctions at all. This has usually occurred when countries have had decisions made by their constitutional courts that it is unconstitutional to punish people for their own behaviours around drugs. So Germany and Mexico have both had constitutional court decisions saying it's unconstitutional to punish people for possession of small amounts of drugs. It was done by a legal move in Vermont as well, where cannabis possession was decriminalised without replacing civil fines in the couple of years before Vermont moved on to actually legalise cannabis supply. But still in Germany and in Mexico, there is formal decriminalisation, legal decriminalisation with no sanctions to replace it because of these decisions of the Constitutional Court. But there's a problem here because in Germany, for example, the Constitutional Court did not decide what the threshold would be for small amounts. And there are arbitrary and variable limits as to those amounts. So, for example, in Berlin, which is a more liberal state, or part of Germany, you see a higher threshold for the amount of cannabis you can have compared to Bavaria, a more conservative part of the country, where that amount is quite low, considering that 30 grams is about an ounce. So in Berlin, they're about the same level of generosity, if you like, as most American states, whereas in Bavaria, they're much lower. In Mexico, we see even smaller thresholds being used, meaning that many people who use drugs continue to be criminalized for their possession, even when it is just for their personal use, because these thresholds are so low. And in Mexico, we still get repeated reports of drug offences being used as the pretext for intervention in violent and discriminatory ways with populations of people who use drugs in that country. Again, this is not, we think about this in terms of whether it goes far enough. And we have another report from the International Network of People Who Use Drugs suggesting that we need to go beyond these limited forms of decriminalisation to what they call full decriminalisation with no arbitrary weight limits, no residual criminalisation, and towards full decriminalisation, which they would say includes legalisation of the market. Now, I would, compared to that call for full decriminalisation that we have from the International Network of People Who Use Drugs, the sorts of calls we've had for these alternatives in international documents such as the European Union Action Plan on Drugs or the United Nations coordinating body call for decriminalisation are much more limited. So the European Union calling for alternative to coercive sanctions rather than clearly coming out and saying that we shouldn't be treating this as a criminal offence. The United Nations, for example, calling for decriminalisation, but without specifying what form of decriminalisation they're meaning, and many countries interpreting this to mean forms of decriminalisation that retain some form of control and indeed punishment for people for use and possession of drugs. So I'd like to leave you with these questions. How can we best reduce the pains of punishment and increase the benefits of treatment while avoiding this increased number of people exposed to state intervention, avoiding the intensification of the control we place upon people by making that net more burdensome and harder to get out of, by avoiding reinforcing the idea that drug use and people who use drugs are always pathological, either criminal or ill. Can we design a system that treats those people as people who choose to use these substances, who may occasionally have health problems that they might need help with, but aren't necessarily either mentally ill or deviant in themselves? And when considering those questions, I'd like you to think about Cohen's warning that he included in his book on Visions of Social Control, that you can't just look to people like me to answer these questions for you. These are not purely scientific questions, and they're not purely political questions. These are inherently moral questions. And so we all have to look to our own moral judgments and discuss them amongst ourselves in order to come up with how do we answer these questions about the right way to deal with the issues that are brought up when people decide to have drugs in their possession. And in doing so, please also be inspired by the example of Allison and Eddie. In his obituary of Allison, John Podmore wrote that Eddie's and Allison's love story was one fueled by a noble passion. And I hope in some small way at least, I've helped to transmit their noble passion onto you to find more moral as well as more effective ways of dealing with drug possession. Thank you very much indeed for allowing me to fulfill this very honoured position of doing this memorial lecture for you. Thanks, Paddy, and thanks to you all.
Thanks very much, Alex. I think that confirms that I made a very good decision 25 years ago, and I think he's progressed massively since. Thank you, Alex, for your thought-provoking contribution, and I'm sure everybody here will take a lot away from what you've said. And I hope you will be able to join us at a future edition of City Health so that we can continue the discussion and debate in person. We now turn to the presentation of the 2021 Paulo Pertica Award. Established in 2004, the award is now given in memory of another close friend and former colleague of mine, Paulo Pertica. He was well known and respected as an advocate for harm reduction, who took his own life in 2019 after a long struggle with mental ill health. He was born in Italy, but spent most of his working life in the UK. He was a fierce and tireless advocate for appropriate services for drug users, especially those caught up within the criminal justice system. I worked closely with him, along with Alex, along with Eddie, along with Allison, and along with a lot of other people, too many to mention. And, sorry, I've lost my place. I should have put my glasses on. And I think he's still very much missed all the time. And events like this just bring back the memories. And I'm delighted to say that to make the award, we're joined by his wife, Pauline, and his two boys, Matteo and Dario. And it gives me great pleasure to introduce them now and invite them to make the award to the recipient.
Luckily, I have got my glasses. So good afternoon, everyone. And thank you, Paddy, for a really lovely introduction. It means a lot to us to know that Paulo continues to be remembered for his work, which was such a big part of his life. We'd like to start by saying a heartfelt thank you to Paddy and everyone at the City Health International for inviting us to the conference here to present the Paulo Pertica Award. Before we talk about our outstanding award winner of 2021, we'd like to say a few words about Paulo. It's quite a poignant event for us, so just excuse our nerves, please. Like all of us, Paulo's experiences in life shaped him, some in a positive way, and others not so much.
But today we're here to share about how my dad used his experiences in life to benefit others. He was the person you would want in your corner if you were having a tough time. He was also a relentless supporter of people in crisis, and particularly people who had problems with drug and alcohol addiction in the criminal justice system. He fought to achieve health equity for some of the most stigmatised people in our societies.
Dad enjoyed telling stories to anyone that would listen, and there were a lot of them. But the one that sticks in my mind is when he was working as a prison drug worker in London. He was visiting HMP Wandsworth when the alarm went off, and particularly surprised. And at the time, he had long hair in a ponytail and a pretty casual look, so he wasn't particularly surprised, although a bit shocked, when in the heat of the moment, a prison warden mistook him for an inmate and pushed him into a cell with another prisoner. As the prison was in lockdown, there wasn't much he could do, so after introducing himself to his new cellmate, he noticed a chess set and was soon engrossed in a game. When the cells were finally unlocked and a very apologetic prison officer offered to escort him quickly out of the prison, he said thanks, but could he finish the game first?
I know that Paulo would be absolutely thrilled to know that the Paulo Pertica Award 2021 is going to Magena Excel, as are we. A doctor and a surgeon, After graduation from medical studies in Krakow, she worked first in the Department of Surgery at the University Hospital of Krakow, and then in the Department of Thoracic Surgery at Zakopane. She spent the next 3 years as a doctor in a mission hospital in Zimbabwe. And after returning to Poland, she took up a job in the prison health service, first in the prison hospital in Krakow, and then for almost 10 years, she held the position of chief prison doctor. During this period, she and the health service office team cooperated extensively with many national and international partners, including the National Bureau for Drug Prevention, the National AIDS Centre, the World Health Organization Health and Prison Project, the Central and Eastern European Network of Drug Services in Prisons, and later with the European Network for Drug and Infections Prevention in Prisons. It was thanks to her efforts that prisoners began to receive antiretroviral drugs on the same basis as any other patients, financed from the Ministry of Health budget. It was also in this period that the first methadone programs were established in Polish prisons. Not without significance was the wide-ranging training activity in public health issues carried out in this period, addressed not only to medical staff employed in prisons, but also including both prison guards and directors. The Prison Health Service logo used at the time, a heart behind a grille, was intended to symbolize the ethical standards binding staff towards the patient, the prisoner. After leaving the prison service, she was a member of the Council of Europe's European Committee for the Prevention of Torture for 12 years, continuing to work on issues relating to the healthcare offered to people deprived of their liberty. Currently, as an expert of the Council of Europe, she continues to participate in various projects related to this topic. Congratulations, Marzena. It's an absolute privilege to present this award to you. Your work over your whole career is a complete inspiration to everyone. Your dedication and significant collective achievements have resulted in many of our most stigmatized communities having a healthier and happier life. Congratulations.
Dear Pauline, Matteo, Daria, dear Paddy. Szanowni Państwo, serdecznie dziękuję.
Cordially thank you for granting me this exquisite award, and I won't be hiding that when I learned that I am a winner, I started to think about it very much because, well, we had this lockdown period and we had the time to stop and we have to summarize certain things. This has been 30 years of my career in healthcare that is provided for people deprived of their liberty. What was said about my achievements, well, I think it wouldn't happen if it were not for my curiosity for the war and my decision to take my job in Africa and Zimbabwe, and I had to requalify from the general surgeon to a multi-specialist in charge of people suffering from HIV or pneumonia or obstetrician, working as an obstetrician, as a pediatrician, as a public health specialist in a mission hospital, including 30 beds. So if on my career, coming back from Africa, if I didn't meet many wise people, such as the heads of the prison service, General Purser, Permiankiewicz, Popiołek, or Mr. Szostak, who supported me in my new projects, As a head of the prison health service, I cooperated with many representatives of the Ministry of Health, but unfortunately, just few of them understood that what's important for the public health is the population of prisoners. I think that Mr. Andriusz was such a minister that the current director at DG Sanko for the European Commission. So these people included Mrs. Anna Maciec-Bogusławska, the head of the National AIDS Center, HIV Center, Mr. Piotr Jabłoński, Mr. Bogusława Bogusław, and the heads of the National Office for Drug Abuse. I remember quite well that we had this long-term negotiations with the former advisor for the Minister of Health. We provided the prisoners to antiretrovirus treatments for HIV. I remember that with Mr. Mark Zagor, we started our training, harm reduction training, and I remember starting of the first, or launching the first national program for methadone in Poland. Well, this event would not occur, today's occurrence, if there were not for my cooperation with Paddy and the Crown Store team. Well, it was, I believe, 2002 or 2003. I remember that when I met Paulo and when he arrived at the conference to Popovo. And I remember that many people who are attending this conference too are so important, because I remember that in 2007 to the conference, and all these achievements were achieved also thanks to the collective work of the whole team, of the Wojtek Rudalski, Halinka Strzelecka, Marek Bujak, the whole office of the health service. So let me also thank for the support and understanding of my husband, who is a psychiatrist, and I think his high moral standards always make him treat a prisoner on an equal basis with his regular partners. And I would like, of course, thank to my late mother that she brought me up and she taught me respect to another human being. And I believe that all of my achievements were also related to the belief in of the 11th commandment, that was defined by Marian Turski, which means do not be indifferent. And I would like to dedicate my award to all representatives of health service who are not indifferent, who provide help to the detainees at police officers, for whom the prisoner is a patient, most of all, who with huge dedication and help to COVID patients, also exposing their health, and to all of them who in this dark room are present in the forest on our national border with Belarus. And thanks to them, many refugees managed to save their life and health. So at the end, let me just address my son, Jasiek, as a small boy who used to participate in all these conferences, and his generation, my son's generation, son, do not be indifferent. This is the address to all his generation.
Marjana brought back a lot of memories of people I also knew. And the one thing that all of those people had in common was they were absolutely terrified of her. She introduced me to the Director General of the Polish Prison Service. We went out to dinner together. And it was just very interesting that the man that had the entire power of the system behind him was looking to her every time before he made any comments to me. You know, is it okay? Can I? But she is a force of nature. She was responsible for us establishing an office for the European network of drug services in prisons in Poland. And I guess she's kind of responsible for us being here today. I remember signing the contract to have the office, which was provided by the Polish Prison Service. And again, the Director General apologised to me that because of the nature of Polish law, he had to charge me something because we were occupying their premises. So they charged me 1 zloty a month, 12 zlotys a year, which I think at the time was worth about £3. So it was a pretty good deal. We also ended up with Jagos as one of our coordinators, and he and I have worked together ever since. And I think it's testament to the vision of somebody like Marzena, who allowed us into the country and who encouraged us to come and take part here. The only thing I haven't done, which she tried to insist, was to learn Polish. I found it completely and utterly beyond me. But then again, I don't think I'm in a minority of one in this room at the present moment. But anyway, I'd just like to say congratulations to Marzena and a big thank you to Pauline and the boys for coming over here and joining us today. And I'll now leave you in the hands of Kasia, if she's about, oh, here she is, to finish the proceedings for the day. Thank you very much.
Thank you, Paddy. Thank you. Well, congratulations to Marzena. Thank you, Pauline, Dario, Matteo, for joining us together. So the first day of the conference came to an end. And as I said at the beginning, one of the GPHN goal is to bring people together. So I would like to invite you all for the less formal part of the conference, for the conference reception, which will take place just outside of this room. So I hope there will be a time and space for our conversations, discussions, and networking. So just to remind you, we will meet each other tomorrow again at 9:30. Keep this in mind. And the final thought is, please bring back your translation devices. So thank you very much, and let's meet each other outside. Thank you.
Thank you.